มูลนิธิเนี้ยทุกท่านอาจจะต้องรู้จักแน่นอนนะคะก็คือเป็นมูลนิธิที่ก่อตั้งโดยรองศาสตราจารย์นายแพทย์วิวัฒนาถนอมเกียรตินะคะประธานราชวิทยาลัยรังสีแพทย์แห่งประเทศไทยค่ะแล้วก็โดยมูลนิธินี้เนี่ยได้จัดงานร่วมกับ iAOC มาหลายครั้งแล้วนะคะในเรื่องของ HRCT ซึ่งจัดมาครั้งหนึ่งในตอนปี 2017 มั้งคะแล้วก็ 2019 นะคะจัดมาแล้ว2 ครั้งแล้วก็ครั้งนี้เนี่ยทางมูลนิธิเนี่ยก็มาให้ความร่วมมือในเรื่องของวิทยากรนะคะแล้วก็เสนอหัวข้อในการที่เราจะมาพูดคุยกันว่าหัวข้อไหนเป็นหัวข้อที่ได้รับความสนใจหรือว่าทางรังสีแพทย์แล้วก็นักรังสีเทคนิคของประเทศไทยเนี่ยควรที่จะเรียนรู้ร่วมกันนะคะแล้วก็นับไปนับมาเนี่ยในการเลคเชอร์อาทิตย์นี้นะคะนับเป็นเดือนที่4แล้วของทาง iAOC ที่เราร่วมกันทำเรื่องของการศึกษาเรียนรู้นะคะทุกอาทิตย์ที่มีทั้งเรื่องของการเลคเชอร์มีทั้งรังสีแพทย์แล้วก็รังสีเทคนิคนะคะแล้วก็มีการในเรื่องของการพูดคุยในแง่ของเรื่องของโควิด -19 ว่ามันเกิดการเปลี่ยนแปลงอะไรขึ้นบ้างกับสังคมรังสีวิทยาของประเทศไทยนะคะเดือนนี้ครั้งนี้นับเป็นเดือนที่4แล้วเพราะว่าครั้งแรกที่เราเริ่มทำ Facebook Live เนี่ยก็คือวันที่19 เมษายนนะคะช่วงนั้นเป็นช่วงที่โควิดกำลังร้อนๆเนี่ยนะคะแล้วก็ทำให้งานประชุมหลายๆอย่างของเราต้องระงับไปนะคะแล้วก็เลยทำให้เราได้เริ่มเลคเชอร์เป็น weekly lecture มาเรื่อยๆก็ถือว่าเป็นการศึกษาต่อเนื่องนะคะของทั้งรังสีแพทย์รังสีเทคนิคแล้วก็ทางคุณหมอผู้สนใจทุกท่านนะคะครั้งนี้อีกเช่นเคยนะคะเราได้รับเกียรตินะคะจากผู้ช่วยศาสตราจารย์แพทย์หญิงศิลนาถ Terpenning นะคะจาก Emory University นะคะสวัสดีค่ะพี่ต่ายสวัสดีค่ะ
สวัสดีค่ะ
ค่ะพี่ต่ายนะคะจะมาเลคเชอร์อาจารย์พี่ต่ายจะมาเลคเชอร์ให้เราฟังนะคะในเรื่องของ cardiac imaging นะคะโดยในครั้งนี้เนี่ยอาจารย์พี่ต่ายจะมาเลคเชอร์ในเรื่องของ cardiac CT นะคะแล้วก็ coronary CTA นะคะโดยที่จะพูดถึงในแง่ของเทคนิคแล้วก็ fundamental concept ที่เราควรจะต้องรู้นะคะก็เลยจะเป็นเรื่องของ coronary CTA กับ cardiac CTA 101นะคะเดี๋ยวยังไงเชิญพี่ต่ายเริ่มเลคเชอร์ได้เลยค่ะแชร์สกรีนได้เลยค่ะ
ค่ะขอบคุณค่ะ
So
today we start with this topic. It is a cardiac CT and coronary CT angiography technique. And please excuse me. So look at the technical evolution of this cardiac CT. It is in the 1970s that electron beam CT was used to detect to measure the coronary calcium score. This was invented by Dr. Agaston from University of Florida, and this is just electron beam CT. And now we went into the multi-detector CT era. I start with 4 detector in 1998, 16 detector in 2001. 64 detector in 2004. The first dual source CT scanner was out in 2006. And to date, we have 128 multi-detector. We have 256, 320, and up to 460. This is Toshiba Aquilon. This is at this time we already have 640. And why we are trying to develop all of this, because we want to improve the temporal and spatial resolution and to decrease the radiation dose. There are challenges of the cardiac and coronary CTA. There are a lot here, but we're gonna go into a few of these. We're gonna talk about radiation dose. We'll talk about spatial resolution, and we talk about the motion, because all of these we see it very often in the clinical practice. For the radiation dose, the purpose is how can we reduce the radiation dose? We can reduce it by using step and shoot technique and using iterative reconstruction or using high pitch or helical scan at dual source CT. And let's start that. So the EKG gating technique in cardiac and coronary CT, we have 2 techniques. We have prospective gating, we have retrospective gating. In prospective gating, it is a conventional scan. It is we call it step and shoot technique, because the patient, the table will move into the scanner, but the tube will fix. So if you write at the scanner, you will know exactly why they call it step and shoot. So when we scan the patient, this is my QRS complex. This is the first QRS complex, the second, the third, the fourth, and so on here. So we scan the patient, this patient at the only one part of the cardiac cycle right here at about this. Suppose if it's 0%, this is 100% of the RR interval. We normally scan the patient around 70 to 80% of the RR interval. This is your choice. You can scan only at 75%, nothing wrong with that. And but when you do reconstruction, you will get only one spot. That you can do reconstruction. But if you choose to do like 70 to 80, you can do reconstruction from 70% to 80%. Normally, the step and shoot technique, how it works, it will scan one beat and we will skip one beat and then scan the next beat and then skip the next beat and then scan. So it's scan one and skip one. So normally, in the fast scanner, it will take like a scan like 3 times, and then you will get everything from there. Can do reconstruction from there, and this is the retrospective EKG gating technique. This is a helical mode. It used to be the main option. It is no longer the main option. So helical mode, what is it? The table will move into the scanner, and then the tube will move at the same time in the helical fashion here. And the radiation dose that the patient will get, this is my QRS complex here, 1, 2, 3, 4. So the patient will get radiation from 0% to 100% of the RR interval here. You can see. So a lot of radiation here are in the retrospective EKG gating. It used to be the main mode, but right now we our coronary CT at Emory, we do it with a retrospective EKG gating, but we use pretty wide range of the scan. We use about 30 to 80% of the RR interval. You can adjust it, but we would just want to cover the systole and diastole on prospective gating. Back to the retrospective gating, why we call it retrospective mode? Because we can go in and do EKG editing. Sometime during the scan, one heartbeat, the patient start having a regular heartbeat, just one heartbeat, and you will see that right away because reconstructed images will have motion. So you can go in and manipulate that beat or even take that one out. So you get rid of the cardiac motion. That's why we call it retrospective gating. And this is the example of a prospective EKG gating. You can see there is a different in density of the contrast from in the aorta, in the right heart, and then up here. So this patient was scanned 3 times. This is one acquisition. This is second acquisition, and this is the third acquisition here. This you will not see this all the time. This at the moment the scanner is really fast, so you won't appreciate much about the different intensity anymore. This one is pretty old. And this is the retrospective EKG gating. You can see that we can see wall motion, right? So whenever you can see wall motion, we scan the patient, not just one point of the cardiac cycle, we scan more than one point. So doesn't mean this is if you do retrospective EKG gating, you can do reconstruction and can see wall motion. But in prospective EKG gating, if you put the range is wide enough, like 30% to 80% of the RR interval, you still can do reconstruction and see wall motion as well. But the image will be jumpy because you're missing information from 0 to 30% and 80 to 100%. You're missing that. Okay, this is the physiologic loops in the heart for the pressure and volume, and related. We will relate that with the EKG, the QRS complex here. This is the first QRS complex. This is the second one. In the systole is fall between 0 to 35% of the RR interval, and then in the diastole is between 35 to 100%. These are I'm talking about the normal heart rate. This is important because when we scan the patient, we love to scan it in the mid diastole around here, around 70%, because at the time the heart will like almost stop moving. So that's gonna it will be the best time to get the images. This is in the normal heart rate. If the heart rate is fast, like 70, 75, so your best look of the heart or cardiac or coronary CT will be at the systole, so will be around here. So if you want a foolproof technique, you probably have to scan from 30% to 80%. So you would get both systole and diastole, and it's still considered prospective EKG gating. This is prospective EKG gating. We used to do this. So this is our QIS complex, and we scan the patient right here, only the certain part of the cardiac cycle. We normally use this technique in the regular heart rate and the low heart rate less than 65. We use this in non-obese patient, BMI less than 30. Why is that? Because the KV and MAS, the MAS is limited. You cannot use a higher MAS like more than 400, 500, 600, depends on the scanner. And if you don't have enough MAS and your patient is big, you don't have enough photon energy to penetrate the patient. We use this in young patient, kids, especially female patient, and we look at the anatomy only. We don't care much about function. This will give you very, very low radiation dose. Only 1 to 4 millisieverts is almost 80% less than retrospective EKG gating. This is volume acquisition, and as we talked earlier, a table moves and the tubes fix. Next one is retrospective EKG gating. So the patient get full blast of the radiation from 0% here to 100% here of the RR interval. This technique is less sensitive to irregular heart rate and tachycardia. Normally, we don't mind tachycardia, even if it is 80 or sometimes in about 95, we can still fight with the fast heart rate. I'm talking about after we try everything to lower down the heart rate, but we could not, like a pre-medication. So we still can fight with that. But what we don't like is a regular heart rate, because in that case, either prospective or retrospective will turn out bad anyway. And in the obese patient, if the BMI more than 30, you can shift to prospective to retrospective. This we talked already. So about the MAS, that you can put it higher than 600. You can put it up to 750, or some scanner will allow you to put in 1,000. I think that is too much. If the patient is really big and you're afraid that you're not going to get a good study, please stop and don't do it, because it's going to give the patient a lot of radiation without diagnostic quality, and it's not worth it. And we do this retrospective gating in elderly patient because we don't care much about the radiation in the elderly. I think it's not fair, but we've been thinking about that. Elderly patient. We look at the anatomy and function. Retrospective EKG gating, I see only two conditions that we use it. One is valvular function. Like the patient has infective endocarditis, you need to do retrospective gating. Or congenital heart that has multi surgery so many times, the heart is so messed up. In that case, you need retrospective EKG gating. Otherwise, all of indication will go to the prospective EKG gating. And this will give you higher radiation dose, approximately about 12 millisieverts average. And this is we use tube modulation with retrospective EKG gating to reduce the radiation dose. And tube modulation will work well if the heart rate is low, less than 65, and it can decrease the radiation dose up to 40%. What is a tube modulation technique? in the past, what we used to do, we scan the patient full blast of radiation from 0% to 100%. And nowadays, what we are doing is this. So we give the patient full dose of radiation during diastole, which is give us a lot of information about coronary artery here. In the rest of the cardiac cycle, we don't need a lot of information, so we can lower down the dose right here. So this diagram, the patient get a lot less radiation dose than the original retrospective EKG getting here. And if the heart rate is so fast, suppose heart rate is 80, and the scanner actually it takes time for the scanner to change the mode from modulation technique to non-modulation technique here. If the heart rate is so fast, the scanner will not have enough time to change that mode. So from tube modulation technique, it's going to go back into the original retrospective gating, so it won't work in the fast heart rate. Iterative reconstruction is the reconstruction software that installed in every new scanner right now. So there's no worry about filter back projection. In the past, the original filter back projection, we've been using that for a long time. The word iterative reconstruction is the generic name, and there is a trade name for it, depends on the vendor. Suppose it is GE Healthcare, so they call it MBIR, or they call it ASIR. For the Siemens, the first generation of iterative reconstruction is IRIS. The second generation is Sapphire. As I remember, this one, Sapphire, will be in the flash scanner. The second generation dual source. And then at the moment, what Siemens is using is Admire. This one is in the third generation of dual source CT, or the fourth scanner. That I know that we have a few in Thailand. And for the Philips, they call themselves iDose, or iDose 4. For Toshiba, they call it AIDR or AIDR 3D. So they're all the same technique, but just different name from different vendors. In a patient who is not, this is 56 years old man, BMI is 23. This is filter back projection. This is iterative reconstruction. Not a lot of different that we can see here. Look at the next one. This is BMI 28, 57-year-old man, and not a lot, almost the same quality image here, but look at this one. BMI is a bit high here, 31, and for me, I think this one look noisier. This one look a bit better. This one is filter back projection, and this one, the one on the right, is iterative reconstruction. And this is really obvious. This is from Discovery. This is from GE. Is ASIR and filter back projection. On your right, on your left is filter back projection, and on your right is ASIR. You can see the difference, very obvious here. And the high pitch scan, what is it? Look at this one. This is my QRS complex. This is my QRS complex, and the scan time is here. So it scanned the patient in less than 1 heartbeat. So the radiation dose is a lot less if you compare to prospective gating and retrospective gating. So this is the only part that we scan the patient, and how the image will look like. It look like this. Very nice and clean here. And this is the volume render from the same patient. And this is it also has diagnostic quality because you can see a stenosis and non-calcified plaque here in the LAD. We talk about pitch because we talk about high pitch scan. The pitch in the past, there is the two meaning of the pitch. Pitch in single slide, the single detector CT, and the pitch in multi-slide detector, multi-slide CT here. So the single slide CT is the detector pitch, and the multi-slide CT is the beam pitch. In the pitch, the definition is the table travel, the length of travel in one rotation divided by the beam width. For example, the table traveled 5 millimeter in one rotation and the beam collimation was 5 millimeter, so the pitch is 1. If the pitch is 1, there's no gap between the slide. If the pitch is more than 1, there will be gap between the slide. This, for example, here, table 5 millimeter and the beam width is only 2 millimeter. So in this case, the dose and the quality of the image will decrease. If the pitch is low here, I'm talking about the single slide CT, and there will be a lot of overlapping. For example, table is moving 5 millimeter and the beam width is 10 millimeter. There's a lot of overlapping here. So the dose and quality of the image will decrease. You pay the price of the quality of the image by increasing the dose here. But I think at the moment, every place have a multi-detector CT. So this will not be a problem anymore. Let's look at the beam pitch. The beam pitch is the table rotation, table length, travel length in one rotation divided by the beam width. But the beam width of the multi-slide or multi-detector CT means the number of the detectors times by the slide thickness. Here, for example, if we have 16 multi-slide CT, the table per rotation is 10 centimeter and the slide thickness is 5 millimeter. So the beam width, put out of that in the formula, the beam width is 1.25. This is the real protocol. So the flash protocol, this protocol, we call it flash protocol, is this one, is the high pitch protocol. And this, I show you an example from the Siemens scanner, the Ford scanner here. So the table move in one rotation is about 36 centimeter. And number of the detector is 192 and the slide thickness is 0.6 millimeter. So the pitch is 3.2. This is the high pitch scan of this flash protocol. All right, and we talk about radiation dose, and next we're going to talk about the spatial resolution. How can we improve the spatial resolution? We can use the high definition CT to improve that. And next, our last topic, it will be a motion artifact. Okay, spatial resolution. What is it? It is an ability to distinguish between objects or structures that differ in density. And high spatial resolution is important to discriminate between structures that are located within a small proximity to each other. The standard spatial resolution nowadays is 0.33 millimeter for in-plane spatial resolution. Okay, there are many factors that affect spatial resolution. Pixel size, the smaller pixel size, the higher spatial resolution. Field of view, the field of view increase, the pixel size will increase, so it will decrease the spatial resolution. So this is important when you scan the patient, you want to do CT chest. We don't need to look at the arms, or we don't need to look at the at something else. So just cone it down a little bit. And you will have a better spatial resolution that way. The focal spot is come with the scanner. We cannot control that. The smaller the focal spot, the higher spatial resolution. Magnification. If magnification increase, the spatial resolution will decrease. And kernel, the edge enhancement. Some PAC system, they have their own software installed in there, like the center, they have edge enhancement algorithm. If you put that in, you will get higher spatial resolution. And slide thickness, the thicker slide, the lower spatial resolution. The detector size, the larger detector size, the lower spatial resolution. Let's see an example here. This is an example of the edge enhancement. Look at this internal auditory canal here. This is the when we apply the edge enhancement software here. See how clean and nice and sharp it is. For the high definition CT, and this is an example of a Discovery CT from GE. it claims that it used gemstone detectors and it has 2.5 times more views per rotation than the usual CT. It is 100 times faster speed. And they say that this is their selling point, is the in-plane spatial resolution is 0.23, which is really, really good here. This is the high definition CT. It is very good for small and peripheral coronary artery that is smaller than 3 millimeter, and it's very good to look at calcified and stented artery. Let's look at this. This is the standard resolution up here, and then this is the high resolution. See, it's really nice and clean. It's get rid of all of this burling here out of the images. And we still can see a lot, we can see the patency of the coronary artery stent. Normally, coronary artery, when it got stented, we always has problem. Is there anything there? Or we don't know, it's too much beam artifact from the metal. But this will help a lot too. And compare that discovery CT of the GE Healthcare. Look at this cement. This is the force scanner, 0.24, not bad, because the GE is the 0.23, so pretty close. Next one, we will talk about the motion artifact. I'm sorry, the motion artifact. When we talk about that, we talk about temporal resolution. And we're going to go into dual source CT motion correction algorithm. And let's look about temporal resolution. Temporal resolution is how good we are in catching with the heart rate, fast heart rate. Okay, here, what can improve the temporal resolution? The number of detector increase the number of detector in the z-axis. That will help about the temporal resolution. We'll show you how. And the dual source CT can help that too. And make quantity rotation work faster, or we can slow down the heart rate by pre-medication the patient with a beta blocker or calcium channel blocker, and we do multi-segmental reconstruction. Okay, let's start with the first one. Let's do the math. One acquisition, the length of acquisition is the number of detector in z-axis times by the detector width. For example, if we have 64 multi-detector CT and our detector width is 0.625, so we do the math, and then it's about 40 millimeter or 4 centimeter. So one acquisition, you will get 4 centimeter coverage of the heart. Think about this. From 64 to 640. This is the real number from 640, and the detector width of the aquilon is 0.5. And each times that you have 32. So one rotation, you cover 32 centimeter of the body. So just one rotation, you're done with the heart. That is why the increased number in the z-axis will improve the temporal resolution. Okay, why the dual source CT can improve the temporal resolution. This is a single source CT here. So this is the source, and then this is a X-ray beam is coming down here, and then it will have to rotate from this point going down 180 degree to this point. So to be able to do reconstruction, the scanner need at least 180 degree information plus beam angle here to do the reconstruction. So it has to move to 180 degree here. The temporal resolution is at one level. And now look at the dual source. So the dual source, the first source is here and the second source is here, is perpendicular to each other. When it's moved all together. So we'll get 90 degree information from the first source, and we will get another 90 degree information for the second source. So this doesn't have to move 180, it's just move 90 degree, and then we get everything. So that is why the temporal resolution in dual source CT is twice better than the single source. The gantry rotation actually is pretty heavy. I used to give this talk once when I was at the University of New Mexico. At the time of 2014, seems like the gantry rotation, the fastest rotation at the time was 330 milliseconds, and that was maximum innovation. And right now is even faster. Is a lot faster. Here is the 250 millisecond. This is from the number. This number is from dual source Siemens, the force here, which come out in 2016 or 2017. Probably the fastest one. Okay, the motion correction, for example, this is the software of the GE Healthcare is snapshot freeze here. So this is 49 years old, heart rate is 51, uh, heart rate is 51, and look at this. This is without snapshot freeze. And when we apply snapshot freeze, and you can see that the motion in this area is all gone. We can see a lot. This is complete occlusion here, cataract 5 here. Next thing that we can do to improve a spatial temporal resolution is to slow down the heart rate. How we can do it? So we give the patient beta blocker, and I have never give the calcium channel blocker, but I have seen cardiologists. Sometimes they do it, not very often. Only sometime when they have allergy or something that cannot use the beta blocker. The beta blocker that we use metoprolol. There are two ways to prep the patient. You can give them oral. So you order the oral metoprolol about 50 to 100 milligrams oral, and have the patient take that 1 hour before come to the scan. If the patient is come to the hospital and we look at the heart rate is still fast, you can give the second dose and wait another 30 minutes. If the patient's heart rate is still fast, that's what you get. You cannot give more than twice. That is enough for the patient. If it's still too fast, two things to do. Don't scan the patient, or go back and get and come back later. May do IV metoprolol later. So the second way to prep the patient is IV metoprolol at the scanner. So one vial of the metoprolol is about 5 milligrams. You can give one dose. If the heart rate is fast, give one dose and wait 3 minutes, 5 minutes. If the heart rate is still fast, give the second dose. You can give up to 5 dose or 25 milligrams IV, and then that is maximum dose that you're going to give the patient. The next medication is nitroglycerin. It's for coronary artery vasodilatation. So we give them nitroglycerin about 1 to 2 tablets, just 1 tablet underneath the tongue, and it's 0.4 milligrams per tablet. And we wait about 6 to 7 minutes and then scan the patient, because at the the peak of the nitroglycerin and maximal vasodilatation. Before you give these two medications, make sure that the patient does not have contraindication for beta blocker or nitro. No caffeine, no coffee, no tea, no Coca-Cola, or any drink that has caffeine 24 hours before the scan. No Viagra, no sildenafil. This is pulmonary hypertension in female. They give the pulmonary hypertension patient in 24 hours. If Cialis is the for the erectile dysfunction. Cialis has longer half-life, so may have to stop Cialis for 3 days before it can come to the scanner. No history of hypertrophic cardiomyopathy or severe aortic stenosis or asthma. You have to dig out the history and make sure, and ask the patient, make sure there's no contraindication. One easiest thing that I normally do, I grab a phone call and ask the clinician, ask the cardiology that they order the study. Hey, is this patient has contraindication for beta blocker or nitro? So I don't have to look into all of those. So, and the breathing instruction is really important to hear how the scanner, the automatic voice from the scanner will say we talk to the patient. Take a deep breath in, blow it out, another breath in, and hold it. So now the problem comes. The second breath, the patient will take a big, big breath, and then they cannot hold it. So they have to let it out when we are scanning them, so that will ruin the study. So I have to tell the patient that the second breath should be the breath that is not too big, not too small, but it's the breath that just right for that person, and that can hold it for 10 seconds. And I always practice with the patient at the scanner and have them hold their breath for 10 seconds. And that helps a lot too. Okay, a reconstruction method. This is in post-processing technique here. This is single segment reconstruction. You get 180 degree of information from one heartbeat. So there's a lot of higher chance of motion will happen here. The dual segment reconstruction, you get 90% of the information from the heartbeat, number one, and you get the second 90%, second degree of the information from the heartbeat, number two, and you put that together. This is gonna less sensitive. So you have higher chance if the patient move a little bit that the temporal resolution is not so bad here. And this is normally we do multi-segmental reconstruction. So 180 degree of the information that we're gonna do reconstruction here got from 4 heartbeats. This has no worry about the reconstruction method at all, because the new scanner these days, they all use the multi-segmental reconstruction. It's not an option for you to choose what you want to do, but it's already chosen for you here. So this is an example of partial reconstruction. The temporal resolution is 250 milliseconds. See how it's like a steps there artifact here. But this one is multi-segmental reconstruction. See how nice and cleaner here, and the temporal resolution is better too. I'm going to show a case because I have a point to show this case and want everyone to get a concept why we're doing coronary CTA. This is a 67 years old man with chest pain. And this is the MPR image. You can see that this is our LAD, this is left main, and our LAD coming down, look nice and clean here, nothing much. And this is the LAD, this is circumflex, this is left main, this is the LAD, and this is the circumflex is here. And this is another view of the left main and the LAD. So I just want to point it to here. There's only a little bit of a stenosis right here in the distal left main, right here at the bifurcation, And this is the cardiac cath. So the patient has the left main stenosis, about 50% here. So this is the slide that I would like you to see. I think it's have a good concept here. The rules of practice. What is the positive coronary CTA and the management? More than 50% stenosis is considered positive coronary CTA. What we do with it? If a patient has positive coronary CTA, they go to cardiac cath. If the patient has negative coronary CTA, they go to medical treatment. So what we say here will affect the management of the patient. They're going to cath them or they're going to do medical treatment. What is significant narrowing of coronary artery? If it's RCA, LAD, and circumflex, it is more than 70%. And if it's left main, the threshold is a bit lower, so it's more than 50%. And when you talk about that, we go into the CATRAT reporting system. We're not going to talk about that today. Okay, so this person has significant left main stenosis. Okay, we look a bit. I know you all probably know about this coronary artery. It's just refresh your memory about coronary artery. I have to thank for my former attending, Dr. Rissing at Indiana University. I was there as a fellow for 1 year before I moved on to Maryland. And we have the right coronary system and the left coronary system here. Left coronary system, we have left main. Left main will have LAD, left anterior descending, and left circumflex. the LAD will be in anterior interventricular groove, and the circumflex will be in left atrioventricular groove. And once in a while, 1/3, we're going to have ramus intermediates. The ramus, so we will have trifurcation if we have ramus intermediates. And the ramus itself will act like diagonal branch, which is a branch from the LAD. From the LAD, left anterior descending here, it will give diagonal branch. So diagonal branch, the number of the diagonal branch that came out of the LAD will give the different segment of the LAD. So the bifurcation of the LAD and circumflex to the first diagonal branch is its proximal LAD, and the first diagonal branch to the second diagonal branch is the mid LAD, and after that is distal LAD. And the septal perforator branch is the branch of the LAD too. The diagonal branch supply the anterolateral wall, and the septal perforator will supply the anterior septum. This is the trick about how to call LAD. Some practice will not use diagonal branch to segment the LAD, but they use septal perforator branch. So you have to talk to your own cardiologist what they use. So you both can have you are on the same page. That you this place use diagonal branch, that place use septal perforator branch. So they are different. Most commonly used is diagonal branch. And the left circumflex will give obtuse marginal branch or OM branch, and this is the same rule as the LAD. The bifurcation to the obtuse marginal, first obtuse marginal branch is the proximal circumflex, and then OM1 to OM2 is the mid circumflex, and after that it is the distal circumflex. Sometimes the circumflex will terminate into OM2 or even OM1, and you don't see the circumflex in the groove, and that is fine because the left coronary system will come and help that out, and it is supply the lateral margin of the left ventricle. Okay, here is the image. This is my left main, and this is my LAD, and this is my first diagonal branch. This is my ramus intermediate. It will act like a diagonal branch, supply the same place. And then this is the left circumflex, and this is my obtuse marginal branch. Right coronary artery. Now we are talking about RCA. It is located in the right RV groove. Here, it gives conus branch, it gives SA nodal branch, acute marginal branch, and sometimes, most of the time, PDA and PLV. So the conus branch supply right ventricular outflow tract. It is important because it is a source of collateral circulation when the LAD has obstruction. 50% of the conus branch is from RCA, and another 50 is directly from the aorta. And sometimes if the catheter got stuck in the origin of conus branch, it can cause arrhythmia too. And SA nodal branch, the branch supply SA node is very, very close to the interatrial septum. 60% of the SA nodal branch is from RCA, and another 40% is from circumflex. So the acute marginal branch is the branch of the RCA here. Is supply the right RV free wall, but we do not use this acute marginal branch to segment the right coronary artery. We'll show you how we segment it. And PDA supply the inferior wall of left ventricle and the inferior septum. Okay, here is the right system. This is my RCA. This is my conus branch. It's going up to the right ventricular outflow tract here. And this is another conus branch from the RCA from different patients. And this one is the MIP image. I want to warn you about using MIP. Please do not use MIP to look at coronary artery. You will make everything looks normal. So for coronary artery, have to look at it on MPR, not MIP. The MIP is just to make it look nice for the surgeon, but otherwise it doesn't useful much. And this is another RCA here, and you see the conus branch is right off the aorta here. And this is SA nodal branch. This is from the RCAs coming back into the intra-atrial septum. This is SA nodal branch. Okay, this is the acute marginal branch, AM1. And here is how we segment the RCA. From the origin of the RCA to the first genu here, or the first curve of the RCA, we call it proximal. From the first curve to the second curve of the RCA, we call it mid, and after that we call it distal. So the left system used branches to segment the vessel, but the right system used location. So it is different. Both right and left can have supply to the PDA or posterior descending artery here. It is in the posterior interventricular groove, and a V nodal branch. Actually, this one is the branch of the first branch of the PLV here, and then the PLV normally supply the infilobasal of the left ventricle. We show you here. So this is distal RCA, and then this guy is coming and trying to go around the left ventricle. This one is PLV. And then this guy is going in between the groove of both ventricle. So this one is PDA. And this is segment coronary artery segment according to the AHA classification. This is different from 17 segment. 17 we show you at the last slide is the 17th segment. So coronary artery dominance is determined by who is supplying the PDA and PLV. Normally 80% is right dominant, 10% is co-dominant, and 10% is left dominant. So this is an example of right dominant. This is the RCA, and you can see PDA is here, and it's also give PLV. So this is right dominant. This is left dominant. This is circumflex, and this is the PDA. I could not see PLV. So I supposed and assumed that this one is the left dominant. So this one is co-dominant. This is my left circumflex, which give me PLV, and then this is RCA, which give me PDA. So this is co-dominant. And this is 17 segments of the heart, and I think it's nice to remember this, or at least know where to look for, because it's important for the coronary artery distribution to look for infarction, especially on the cardiac MRI and echo, and look at the wall motion. And I think that is all I have. Hello, Tanya.
เดี๋ยวนะคะโอ้ยขอบคุณมากค่ะ thank you so much ค่ะพี่ต่าย it's very impressive lectures and I know this is like a very detail oriented study. It's not only like for the radiologists but also for the technologists who need to know the detail of the patient in terms of like a patient preparation and like a checklist for the patient. พี่ต่ายคะ ideal heart rate เนี่ยคือเท่าไหร่ในการทำ
less than 65. The heart rate should be less than 65. It depends on the scanner. If your scanner is so fast, I can fight with 85 or 90. I can fight with that. But your scanner has to be very good. But if you have 64 slide, don't risk. Don't take risk. Yeah. Okay. So ideally less than 65. Even if the heart rate, suppose we did like the day before is 95, but we have the dual source, so it's fast and like or sometimes it's really fast and the clinician have to have that. So we do fresh sometime, but some turn out good, some turn out bad. Not always good.
There is a question from the Facebook Live. asking about like the technique about the CT. Let me see. เทคนิคสไลด์ต้นๆสำหรับเครื่อง CT กี่สไลด์คะ
At least 64.
So I mean like you recommend to do like a CTA coronary or cardiac CTA starting at the 64 slices?
Yes, at least.
At least.
Mhm.
I think like right now.
But 64, I think to me, I did it on when I was at IU, I did it at the VA at IU. It is 64. Take a long time. So it's even for me, people will say at least 64, but for me, I think 64 is not enough. At least 128. For me, I would say 128.
I think in Thailand, I think like right now most of the hospital have like a 64 slices. Only some hospital that has 16 or like 4 slices.
Oh no, don't do that.
Yeah.
But 64 is okay, but you have to prep the patient very well. The heart rate have to be like sinus rhythm 65 or less.
So what is like the key checklist for the technologist? So when like we have this patient come to and like this is like the most important message that you want your technologist to know before scan the patient.
Yeah, normally technologists at Emory, they're pretty good. They check out everything. They read the patient's record. They know they don't check the medication for us. The medication and contraindication is our job to check with the patient and the medical record. But they will check everything else like a contrast reaction, renal failure, chronic disease. Because Emory, when they do scan, they don't do BUN creatinine. They just go ahead and do it. Not even, they don't, they're very brave. So that is not our policy. We don't have to check BUN creatinine. And even, they don't check it. And once in a while, they, if that patient has no underlying disease and healthy before, we don't check it. But they have like some hypertension or diabetes, we will check it. And I don't have to worry because I have a fellow. She's really detailed, so she's really good. She check out everything, and then she'll come and tell me, okay, this is. Okay, let's go do it. So normally check BUN creatinine, prior surgery, what they're looking for. Are they looking for a lima graft? Because that will change the FOV from the just routine cardiac to cover the aortic arch and cover the origin of the lima too. And what are they looking for? What else? History of surgery is important. Stent, the patient used to have stent. Stent is always a problem because it causes a lot of artifact. Most of the time, we don't see very well inside the stent. Yeah. And what else? Contrast reaction. You have to do the patient full prep from home. Which take a long time, like for 13 hours for prep. Those. Yeah. If I think about something else, I think about technologies. We'll talk about that later.
Yeah. So in terms of contrast volume and contrast concentration, because I mean like because I'm doing a lot of like a pediatric patient, so we normally do like a iodine like a 300, not like a 370 iodine concentration.
Yes.
But for the cardiac,
at least 350.
350. Okay. And how about the contrast volume?
Yes, but I have seen people use the 320. It's not bad. It's not bad. But Emory use 350. They use only one contrast, isovul, I think, and but I would suggest 350 and up or 370, and because as you know, if you have better higher concentration of the iodine, you have better enhancement. Yeah.
And also like in terms of contrast volume.
Oh, the volume, this technique is really complicated. So there are many ways to do this. So you use two cylinders system or three cylinders system. If you use two cylinders system, one gonna be a full dose of contrast, and you can do a few way. You can calculate from the patient weight and the injection rate and the delay time, and I'll do the math a little bit to trailer for that person, or you do like maybe 80 cc of the full a full strength contrast, and then followed by saline, 100%. Another saline, and it's in the same injection rate is about like for Thai people, I think 4 cc per second is good enough. Suggested from IU used to use 5 or 6. 5 for big for average person, 6 for a big person. But I think what we use here at Emory, we use 4 to 5, and it turns out okay. It's not, it doesn't look so bad. And what about the system? If you use the first link full dose, full strength of contrast, followed by saline, that in that case you will opacify the left heart. Sorry, the right heart. And there people don't like that because sometimes there's interfere seeing the coronary artery. So lately I do not see, except at IU, they use one full dose or full strength of contrast and one saline. University of Maryland will use full dose, half and half, and then the saline. And as the same as Emory, we use full dose, half and half, and then saline. So in that way, you opacify all of 4 heart chambers, everything.
So it's mean like
But
a double injection, like you inject the first
yes,
syringe, and then like the second injection with the second syringe, like a second
yes.
half
Yeah,
dose.
it's in the system. You just put the contrast in the system. It's automatically with the connect with the scanner. It knows what to do. So actually, we have 2 syringes. The first is the full strength, and the second syringe is the saline. When we inject the first one, and then in the second phase, there's going to be half and half. It's mixing by itself, and then it's going to the patient. So we don't have to do anything. It's already calculated. Yeah.
So which system do you recommend? Like a 2 syringes?
I like
syringes?
these the full dose, half and half, and then followed by saline, because using like the IU Indiana University use is too complicated, and I don't think it's hard for technologists to how weight, how many kilograms, how many cc, how are we going to inject this 5 or 6 cc per second, and you have to do calculation. You have to look at the delay time and put that into the formula and come up with this amount of contrast. It's 86 cc for this person. It's just too much. I don't think that it's important. So by using this, is like I know that it's not tailored for any patient, but it doesn't hurt, and it turns out well too.
I see. So one more questions. If you have like a 64 slices, CT 128 or 320 slices CT, do you change the parameter in terms of KV? KV and MA, like a parameter, is it like still the same parameter, or do we need to change anything?
Yeah, I have not, because we all use only one scanner.
Okay.
And I have never. I don't know. We use only one scanner here since I started, so I do not know. Let me think, and I don't want to give you a wrong answer.
Yeah, because this is a questions from the Facebook Live about like
that I would say go into this website, SCCT, or CT is us. CT is us website will have the scanner, the vendor of the scanner and the protocol and the number of detector. They have everything for protocol.
Oh, I see. Okay.
CT is us.
I found it. I can put this on the Facebook Live.
So that you can find everything. You can find every vendor, every number of detector and protocol. What protocol do you want to see? Yeah. I can find with that, but your scanner has to be very good. But if you have 64 slides.
Hello สัญญาณเหมือนขาดไหมคะพี่ต่าย Hello
พี่ไม่ได้ยินนะคะ
Hello ค่ะ Can you hear me?
Yes.
Yes. So you talking about like the CT is that we can go and check on the vendor, on like the technique and parameter specific on each vendor.
Yes, it has the detail. I seen a few, but I did not check on everyone. Check on every single vendor. Here I cannot answer because I have never used 64 slide.
I see. Okay.
And what I'm gonna say. For the 64 slide, I have been using that for one time at many years ago at the VA in Indianapolis. So I would say if you use 64 when you trigger the trigger out from the aorta, I suggest to use the ascending aorta because most of the time people will try to avoid the streaky artifact from the SVC that's coming in and try to use descending aorta. But I would say ascending aorta in 64 slide because it's just so slow. It's just so slow. If you go to the descending aorta, it takes time to scan to blood to go down, and it's already past the ostium of coronary artery. I think for my idea, I think ascending aorta may be better because one is trigger and it will start scanning. Better than it's going down into the descending and then you start scanning there. Maybe a bit too late.
I see. Yeah. I think that's it for the questions. There is one comment. Hello พี่ต่าย from ศิริราช
ใครน่ะ
เดี๋ยวต้องดูไม่แน่ใจเหมือนกันค่ะขอบคุณมากเลยค่ะ thank you so much ค่ะพี่ต่ายขอบพระคุณมากๆเลยที่มาเลคเชอร์ให้ในวันนี้ได้รับความรู้แล้วก็ได้รับเทคนิคในการตัดภาพในการสแกนภาพเยอะแยะมากมายเลยค่ะแล้วก็มีได้รีมายด์ตัวเองด้วยหลายอันเหมือนกันค่ะพี่ต่ายมีอะไรจะฝากไหมคะรังสีแพทย์ที่จะต้องอ่าน Coronary CTA หรือว่านักรังสีเทคนิคว่ามันมีอะไรที่จะต้องรู้เป็นพิเศษไหมหรือว่ามีอะไรที่จะฝากให้เป็น take home message กลับไปก่อนที่จะปิดเซสชั่นค่ะ
ค่ะก็มีสไลด์ที่บอกว่าเป็น rule of practice อะค่ะคิดว่าอันนั้นน่ะสำคัญเพราะว่าจริงๆแล้วถ้าเราพูดอะไรไปใน report เนี่ยมันสามารถจะไปเปลี่ยน clinical management ได้อันนั้นเนี่ยคิดว่าเป็น key เลยแหละแล้วก็ส่วนเรื่องเทคนิคอะไรพวกเนี้ยนะคะมันพี่ไม่ได้มารู้เรื่องอะไรเยอะหรอกก็คือมันรู้เรื่องตอนทำงานนี่แหละก็ทำไปหัดไปลองนู่นลองนี่ลองกันไปเรื่อยๆเพราะฉะนั้นเนี่ยถ้าใครแบบภาพออกมาไม่สวยก็ต้องใจเย็นแล้วก็อดทนหน่อยลองกันไปเดี๋ยวก็จะรู้เองว่าทำยังไงมันถึงจะออกมาได้สวยขึ้นนะคะอดทนค่ะยังไงก็ขอบคุณพี่ต่ายมากๆนะคะที่มาเลคเชอร์ให้ในวันนี้ค่ะ